Yes, Mr. Pranjal, begin.
Just a minute, ma'am. It's going to live.
Good evening. Good evening, everyone.
Good evening, ma'am.
Good evening, किरण जी।
नमस्ते डॉक्टर साधना।
आप ही को फोन लगा रहे थे।
Live now.
नहीं बस
Can start.
मैंने ज्वाइन कर लिया। नमस्कार डॉक्टर सुषमा
नमस्कार
जी।
Good evening, all of you. I welcome you, all of you, on a North India Gynecology Forum, NIGF Expert Speak Series 2. So I hand over session to Dr. Ritu Srivastav. Dr. Ritu Srivastav is a director and consultant at Savitri Clinic and Research Center. So I hand over session to Dr. Ritu, ma'am.
Thank you very much, Mr. Pranjal. Good evening, everybody. Welcome all of you to the NIGF Expert Series 1. The theme for today's series is precocious puberty. Now, let us begin the webinar on an auspicious note with the recital of Saraswati Vandana. Now I invite Dr. Sadhna Gupta, Madam, for welcoming Dr. Sharda Jain, patron of NIGF.
Thank you, Ritu. It's a real great pleasure that just after Holi celebration, we are all set for our first Expert Speaks North India Gynae Forum series. And it is a great pleasure to welcome our all dignitaries, our esteemed guest, chief guest, Dr. Manju Verma, Dr. Sushma Chawla, Dr. Sharda Jain will be joining with us, and who is always a guiding force of inspiration, force and source of inspiration to all of us to do everything at the level of NIGF. And in a very short span of less than 2 years, we have been able to connect with great teachers, with great experts, with great clinician, and with great innovator. And we have such a lot of talent at the level of North India Gynae Forum, which is an association of first of its own kind, which covers 7 states and the 2 union territories. So a warm welcome, and the idea of expert series was long before, around 2 or 3 months. I had this thing in mind that we need to have the expert, and the second thing, which is one of the very important aim of NIGF, it is a well-known expert. Yes, they are known by everyone, but we have a lot of talent and expertise in the young and the mid-level generation, and this is one of our aim of NIGF, to bring that talent that have got the updated knowledge, enthusiasm to work for the society, and the networking with all the colleagues, with all the subspecialties. So today we have what is the theme, that is the precocious puberty, and we seek inspiration always from Dr. Sharda. Then if Madam has joined, we will just invite her. So please stop this slide share. Pranjal, please stop this slide share. So today we have taken the theme of precocious puberty, and it is none other than Dr. Smita Jamchandran, who will be our first speaker of this inaugural series. And this topic has actually haunted me a lot. When I see the young girl menstruating with a lot of fear, and the parents are having so much of anxiousness, and actually many gynecologists, including me, we are sometimes lost that how to approach and how to make communication with the girl who is still a child. So a warm welcome to everyone, and it is a great pleasure to have Dr. Sushma Chawla and Professor Manju Verma as our chief guest, who will we are blessed to have their blessings. And please flash the CV of Professor Manju Verma. Actually, both are so close to us, both are so respectable to us, that we know them by our heart and the mind. So Dr. Manju Verma is a president of UP chapter of North India Gynae Forum, has been head of the department. Can I have CV of Madam Dr. Manju Verma? Pranjal? She has been the head of the department for a long time for the LMLB Medical College.
Pranjal, please take the CV of Dr. Manju Verma.
Yes, yes.
Yes, ma'am. Yes, ma'am.
Yes. Yes, next,
yeah.
So, yes.
Yeah.
So she has been awarded with a lot of gold medals, and I'm privileged that we share the same alma mater. We are alumni of SN Medical College, Agra, and she is known for her not only the teaching capability, but a discipline and a generation of students owe their career to Madam. So Dr. Manju Verma, it's so great to have you, and please bless us with your pulse of wisdom. Dr. Manju Verma, ma'am.
Was present, yeah.
She is.
I think she has disconnected. Yeah, ma'am is there.
So in the meantime, we introduce our beloved Dr. Sushma Chawla, ma'am. Please flash her CV. She is a laparoscopist, hysteroscopy, colposcopist, and IVF expert, and she is honorary professor ICMCH, and runs a Chawla nursing home at Jalandhar. Joint secretary, she has served many organizations. IMA, NAT, she has been president IMA Jalandhar, member of Juvenile Justice Board Jalandhar, member of Child Welfare Committee, and Vice President Arya Shiksha Mandal Kanya Mahavidyalaya. So she is known for her immense commitment to social work, and whosoever doesn't know that she is an elegant dancer, and she can make you dance at any tune, whether you know dance or don't dance. So we welcome Dr. Sushma Chawla. So please bless us, and by the time, please, Pranjal, have a look that Madam has connected or not, Dr. Manju Verma, and stop the slide share.
A very good evening to all of you. Thanks a lot, our President, Dr. Sadhna Gupta, for a very lovely and a very kind introduction. And this topic is such an important one, which actually goes to the pediatrics, but we as a gynecologists must also know about it, because many children, they come to us. but in my lifetime, I've not seen many. But one child we had in our own family, when he's about now at this time, 6 feet 6, he attained this much height. The pediatrician used to stand on the chair to see the height. So that was the thing. And they were thinking, what should we do with this child? Because later on, the bones, age, and everything is going to go haywire. So I think it is a problem when it comes to, one has to really serious think about it. But whether the treatment goes to the gynecs or to the pediatrician, that we have to decide, or it is a combination of both. So today we are discussing a very important topic. And I wish all the success to our panelists and to our very nice, the person who's going to talk about it. So I wish you all the good luck. So we learn together. Every time there's a webinar, there's always something to add on to your own knowledge. Thank you very much for inviting me as a guest. Thanks a lot.
Thank you, Dr. Manju Verma. We are waiting for your pulse.
I've joined, sir. There was some problem in the net. I don't know what happened. So again, as a ritual, very, very good afternoon to everyone again. And it is an absolute honor, to be addressing such an august and intelligent gathering, And I extend my heartfelt thanks to the godmother, Dr. Sharda Jain, President Dr. Sadhna, President-elect Dr. Ragini, Secretary General Dr. Mala Srivastav, and for making me a part of such an important and prestigious webinar. The topic is is very, very complicated as well as interesting. Precocious puberty. We all know that the puberty is a very, very important sign as far as the identity of a person is concerned. And we define, I think the details will be told by the speaker, Dr. Smita Ramchandran. But before 8 years in girls and before 9 years, if the signs of puberty come, it is said to be precocious puberty. And to understand this, the etiopathology has to be understood very, very, rightly. And we know there are so many etiopathogenic factors. It can be, central and peripheral, maybe, gonadotropic dependent, gonadotropic independent, precocious puberty. They can be, incomplete and complete puberty. Precocious puberty also can be there, and the incomplete can be, they can be, premature thelarche, premature menarche, and premature the pubarche. All these things can, this is a very, very interesting, very complicated subject on which, Dr. Sadhna, you have chosen a very, very interesting topic. I think everybody should understand this is very important, and we have got a very important, very, very eminent, I should say, person like Dr. Smita Ramchandran to be throwing light on this subject. And I would definitely like to give my wishes and say, best of everything for the future. And all the speakers and the panelists, Dr. Kiran Pandey and all the panelists, and I'll fail in my duties if I don't say thank Dr. Ritu. He's been constantly, approaching and reminding me about this webinar. I'm really thankful to you, Ritu, and I am thankful to everyone here. And let us not be between me and the speaker, because it is really a very interesting topic, and I would like to listen to it. Thanks a lot, everyone.
Thank you, ma'am. Thank you. So with this, our inaugural function is over, and Ritu, please, you go for the scientific session.
Okay. Now let us start with the scientific session. And in this, the topic would be precocious puberty and short stature, breaking the nexus. To grace the occasion, our experts are Dr. Kiran Pandey, madam. Please play the CV of Dr. Kiran Pandey, Pranjal. Dr. Kiran Pandey, yeah. Madam has been professor and former HOD, GSVM Medical College. She has been Professor GMC Jalon, and she is Chairperson Medical Education Committee, FOXY, and President of various societies. We welcome you, ma'am.
Thank you. Thank you very much.
Dr. Madhu, madam, she has been ex-professor and HOD, GMC Amritsar, and SGRD IMS and Research Amritsar. And she has been chairperson and ex-presidents of various societies and has over 105 publications and contributed 10 chapters. Welcome, ma'am.
Good evening, everybody. Good evening.
Dr. Chandan Kachru, madam. Dr. Chandan Kachru, madam, is a consultant, obs-gynae and adolescent health specialist, Cloud9 Hospital, Gurgaon, has received master training in Switzerland and London and has many publications. Welcome you, ma'am. I think madam is not available. Oh, yes. Then Dr. Anupma Bahadur. She is professor and head of the Department of Obs-Gynae, AIMS, Rishikesh. Madam, we welcome you. Now, I would request Dr. Smita Ramchandran to please come.
Please introduce her.
Carry on the yarn. Dr. Smita Ramchandran, madam, I'm going to introduce her. Yeah. Madam is senior consultant pediatrician and adolescent endocrinologist at Venkateshwar Hospital, Dwarka, BLK Max Hospital, Pusa Road. She has co-authored books on pediatric endocrinology and has over 35 publications nationally and internationally. Welcome, Dr. Smita. We are over to hear from you. Thank you.
Dr. Ritu, so much. First and foremost, I have to say it is an honor and I'm blessed to be able to present something on this topic in front of such esteemed doctors who are stalwarts in the field of obstetrics and gynecology. Sadhna ma'am, I cannot thank you enough for always encouraging me and giving me such a huge platform. Like Manju ma'am had said, this precocious puberty come to pediatricians, but honestly, most of the time they come first to you. You know, anytime a girl has early periods or early physical changes, you are usually the first step of contact with the patients. So without much ado, I'll start my presentation for today. So, sorry, one sec. Yes. So before we start all this, it's just a quick view through of what are the factors which result in the onset of puberty. A lot has been understood more after the identification of the peptide kisspeptin, which affects the hypothalamus, which in turn releases the GnRH, gonadotropins, which instead lead to the cascade of events and hormone release, which leads to the onset of puberty, both in boys and girls. So what happens is, and what the most important thing is, the pulsatile release of gonadotropin, which occurs under the influence of the hypothalamus and the kisspeptin, resulting in the enlargement and maturation of the gonads, which is the ovaries in girls, leading to the secretion of estrogen and secondarily the appearance of the secondary sex characteristics. Most important is what we need to remember is the pulsatile secretion, because this is what is going to help us when we're learning to manage it as well, because this pulsatility is what will lead to suppression and in turn management of precocious puberty. So the primary hormone responsible is the hypothalamic gonadotropin, which when released leads to the cascade, and it is like Manju ma'am had said, gonadotropin dependent puberty, which is central puberty. When it is not related to the release of gonadotropin, it is secondary or peripheral precocious puberty. And a lot advancement has happened since we've identified these trigger points, which are the kisspeptin genes, which is the KIS1, KIS3, and MKRN3. So what is precocious puberty? Precocious puberty is defined as the appearance of secondary sexual characteristics before the age of 8 in girls and 9 in boys. So again, what I like to stress upon, it is the appearance of the first secondary sexual characteristics, which can be central if it is gonadotropin dependent and peripheral when it is independent and not dependent upon the hypothalamic stimulus. So the pubertal onset normally has been defined as a sequence of events where it starts usually with thelarchy, which is breast budding, which is the first sign, which can be followed by 6 to 12 months by pubic hair, axillary hair, and each stage of puberty lasts about 6 months. So from the onset to menarche, the last stage, is about 6 months each. So the Tanner staging of first stage is prepubertal, 2 onwards is when we state as onset of puberty, and stage 5 is adult. However, we need to remember is not always these events happen in a sequence. Pubarchy, axillary hair can precede thelarchy and vice versa. So any one of these symptoms in a child less than 8 years, a girl, and less than 9 years in a boy warrants investigation. So like I said, Tanner staging, it is important to remember our Tanner, because if your child is Tanner stage 1, and sometimes because of obesity and, weight gain, sudden weight gain, there can be an appearance of thelarchy, but on examination, you'll know it's not thelarchy, and a Tanner stage 1 child does not warrant any kind of evaluation. Like I said, the progression from stage 2 to stage 5 approximately is about 6 months each stage, lasting 1.5 to 2 years from the onset to the completion of puberty. So what are the differences between your central and peripheral? Central is what we call true precocious puberty because of the cascade of events originating from the hypothalamus to the gonads and in turn release of the hormones. It is isosexual. It is associated with a rise, most importantly, in the LH and FH hormones from the pituitary gland, leading to an increase in the estrogen. The treatment for this is gonadotropin analogs, which we give. Peripheral, on the hand, it is not dependent on your hypothalamus. It may be isosexual or contrasexual. The progression may not be in a certain order, may be restricted to any one stage. The hormone rise that we usually see is an estrogen or a testosterone. LH and FSH in the peripheral puberty is not raised. And the treatment is mostly treating the cause. So no GnRH analogs are required here. So therefore, differentiating between the two becomes extremely important because the follow-up leading to menarche is different in both, and the treatments are completely different in central and peripheral. So what are the common causes of gonadotropin dependent precocious puberty that we see? Maximum number of cases we see is idiopathic. A lot of time there is a familial history also, but of late we are seeing that even when the mother has a history of menarche, which is at a later age, the daughters are presenting with early onset puberty with no underlying cause. So idiopathic forms the bulk of cases that we usually see. Then there are any CNS cause, which can be a trauma, tumor, radiation, any post-op encephalitis, hydrocephalus, infection cyst, is a risk factor for early puberty. Children with mutations also, the ones I mentioned earlier, have also a higher risk of early puberty. The ones with genetic mutations are the ones who are extremely precocious. And whenever you see a child less than 6 years, they warrant additional investigations. The causes for the independent causes, which are the peripheral causes, are mostly autonomous gonadal functioning lesions. So one of the common multi-endocrine reason we see is McCune-Albright, which leads to peripheral precocious puberty, hyperthyroidism, and high levels of estrogen, Peutz-Jeghers syndrome, testotoxicosis in boys, and ovarian cysts in girls. Sometimes even in severe primary hypothyroidism, we can also see early onset menarche in girls without the whole sequence of thelarchy, pubarchy. And these girls will again be extremely short and very young. And the treatment would only be treating hypothyroidism, and the entire symptoms get resolved. Ovarian tumors, testicular tumors, HCG secreting tumors are another set of tumors which can result in peripheral precocious puberty. Adrenal disorders is a main cause again in children, especially congenital adrenal hyperplasia. The salt wasting or the simple virilizing times are the common ones which can result in this. But you also need to have a high index of suspicion in the non-classical type of CH also, because these girls can have two spectrum of diseases ranging from early peripheral precocious puberty. The second spectrum is reproductive problems like miscarriages, inability to conceive, and hirsutism. So CH and adrenal disorders are a set of disorders which have a lot of overlapping physical features. So why is puberty, if it is a normal phenomena, a cause of concern, especially in today's time when we are seeing a slight demographic change with the early onset of features in girls and boys alike, more so in girls, but definitely in boys as well. So initially, the parents are very happy because there is an accelerated linear growth. The child is always usually a history of one of the taller children in class. So this is actually a deterrent because they will never come to you because the child is growing tall. But it is a red flag sign for the treating physician, pediatrician, gynecologist that if there has been a height spurt, suddenly she's pulled height, maybe she has gone into puberty, even if the menarche hasn't happened, because the accelerated phase happens before menarche in Tanner staging. So this is one of your first red flag signs without any investigation, which will give you a clue that to suspect puberty. But however, this accelerated growth means accelerated bone age, leading to early epiphyseal fusion, which converts to what? A reduced eventual final adult height. And yes, less than 8 years, they are kids, they are children. They do, half of them don't even know what periods is because the mother wasn't expecting it. The school doesn't educate you before you are a certain age. So they don't know what is happening. They are scared. They cannot manage it. And honestly, they should not be at this age managing it as well. So what are the first set of investigations that we should do? So the first set that any child who walks into my clinic is a bone growth chart that I plot. Any child who's had a height spurt gives you a very good clue. It is in fact one of the best clues to go forward with your investigation. X-ray for bone age. A child who's into puberty, stage 2, 3 will definitely have a bone age which is advanced. Bone age advanced more than 10% of chronological age is taken as bone advancement. Hormonals, testosterone and estrogen in boys and girls respectively. LH, FSH, 17-hydroxyprogesterone to rule out adrenal causes. The thyroid profile. And like I said, if the precocity is less than 6 years, especially in girls, then an MRI is also warranted to rule out adrenal causes. Ultrasound of both testes in boys and of the abdomen in girls to find out the uterine size and the ovarian volumes. Ovarian volume more than 2 cc, uterine length more than 35 mm are pointers towards onset of puberty in girls. Of course, to differentiate between central precocious puberty and peripheral, the diagnosis test is GnRH stimulation, in which there will be a surge of LH and FSH, which is diagnostic and also helps to differentiate whether it is central or precocious, which again will tell you how to treat. So the management is GnRH analogs, which are the standard care of treatment worldwide, FDA approved, endorsed by multiple endocrine societies. How do they act? This is where what I was talking about earlier, the pulsatility of the GnRH release comes into play. So what happens is these analogs suppress the pulsatility. The pulsatility, when suppressed, in turn leads to suppression of the LH, FSH, and in turn leading to suppression of all your secondary sexual developments. These are primarily available as depot preparation. Currently in India and worldwide also, we have India, we have 2, triptorelin and leuprolide, which are as monthly and 3-monthly depots, which are given and need to be repeated at regular doses. They are given 8 to 10 weekly, depending upon hormonal suppression, stage of puberty, whether we are stopping it after the onset of menarche or at what stage of puberty. Outside India, we have further options of subcutaneous implants of goserelin and hysterelin implants, which are, once in 3 months or once in a year implants are there. These are, however, not available in India. This is, however, the standard care in US. They do advise a lot of hysterelin implants. So what are the indications for, so any child who's had puberty, early puberty, should we treat? So the absolute indication is central precocious puberty, precocity by definition, less than 8 years in girls and less than 9 years in boys. 8 to 9 years is an age group there where you have to decide case to case, seeing the child height at the time of presentation, the bone age. Bone age will also tell you how much time the child has left to grow for her to attain her final height. So if you feel the bone age is very advanced, the child is still very short, compounding the fact would be familial short stature, the parents are short. So that the likelihood of this child reaching anywhere near an average height, even a 5'1" or a 5 feet, is difficult, is that gray area where you treat girls between 8 to 9 years also. But anything less than 8 years in girls and 9 years warrants treatment. Another condition that we like to treat is kids who are growth hormone deficient. So these children, by virtue of their growth hormone deficiency, which can either be idiopathic or any acquired cause of growth hormone deficiency, secondary to malignancies, CNS causes. So these children by far are already faltering in their height. Onset of puberty will lead to sudden advancement in bone age, early fusion of bone age. So the years of growth these kids have is reduced. So the final height is going to be compromised. So these are another subset of children that we should take into consideration for pubertal suppression. So the question that I get asked is, why only growth hormone deficiency? Why not idiopathic short stature and SGA children? So SGA is another group which I will be briefly touching upon, small for gestational babies, because these girls, by virtue of their impaired growth hormone axis and endocrine axes which are impaired, are at a higher risk of developing precocious puberty. So if there's a history of small for gestational babies, that also gives you additional information and indication to maybe treat these children. So this is an article which was published with a good number of children who treated children with idiopathic short stature who had early puberty. So prolonging the growth plate fusion gives you more time to grow. For most of the adolescents, the benefits of treatment does not outweigh the entire discussion, depending upon how short the baby were. However, LHRH treatment should not be prescribed to every child who's short. This is in into the group where they are short and they have early puberty. If puberty is at normal age for an adolescent who's short, stopping puberty progression is not an option. So how do you monitor? So the most important thing is that you will see once you start your analog treatment is these children, most of them would have had a height spurt. So there will be a slowing of height velocity. What we need to understand is this slowing of height velocity is an effect of GnRH analogs. Why? Why? Because we're suppressing puberty. So hence we're suppressing the pubertal spurt. Hence, when the height velocity slows, it's an indirect indicator that the bone age progression, which was happening, has also gone back to the prepubertal phase. So the child should continue to grow a minimum of about 5 centimeters an year on GnRH analogs. Then the bone age advancement starts slowing by 6 months. By 3 to 6 months, the pubic hair growth ceases. So once the hair growth has started, the hair which has come may not fall off or regress, but the appearance of newer follicles would stop. And of course, again, the gold standard is to check for LH stimulation, LH values, which is usually done after the test to find out if the values are suppressed, which is, of course, the most gold standard for finding out if your suppression is adequate or not. So what are the clinical evidence of efficacy? Like I said, the height velocity slows, the regression of the physical symptoms, thelarchy stops at this stage, breast budding, which has started, also stops. So most of the time, these girls present you with breast budding. Breast budding or thelarchy can start unilaterally or bilaterally. They can be asymmetrical. What is to be remembered here is budding will not come as a mound in the beginning. It will just probably come to you in the beginning as pain. These girls will only complain of pain in the chest, especially around the nipple area. But the pain is also not very severe. It can get missed as an injury while playing, got hurt, fallen. So I've had 1 or 2 girls who've come to me because of budding, who've come to me after FNACs because they've got budding in the breast. All the poor child needed was somebody to understand that it was onset of thelarchy and not some asymmetrical growth under the nipple. On testing, the child was precocious puberty, treated with a GnRH analog, and the breast budding suppressed. The pain goes away. So, and final, of course, the outcome is these kids attain close to their predicted adult height. So, what is when you should consider treatment for sure when there is central precocious puberty, which is progressing. So sometimes the thalaki might start, but the bone age advancement is not there. So it may be very slow progressing. This set of children, you can wait and watch. However, any stage 3 SMR needs to be treated. Any rapid linear growth, a pubic height spurt has happened. You know they're progressing fast. They merit treatment. And again, a brisk tempo or a fast tempo of puberty progression also has a higher risk of these children remaining short for the adult height, and again should be considered for puberty suppression. So for girls who have SMR staging 2 are the girls that we can wait and watch. If they're not progressing from one stage to another, 3 to 6 months you can wait and watch, but every 3 months you should be monitoring them, because if the spurt starts, you should be able to intervene fast before they hit menarche. So we have started. What is a good age to stop? Ideally, the age is we can stop anytime between 10.5 to 11.5. Why this 1 year gap? So this 1 year helps in those girls who are especially faltering for height. So if they've not, their parents are short, their total height itself is not very great. These girls are the ones you can stretch to 11.5 and you can continue till then. Or if the bone age in girls is beyond 12.5 years, you can stop the treatment. And if the bone age is beyond 14 years in boys, you can stop it. Anytime after 10.5 years, you feel the child has attained the final height. The parents feel she's emotionally mature enough to handle her periods. Anytime after 10.5 years, we can stop the treatment and wait for puberty. Puberty usually resumes 6 to 12 months after stopping the treatment. So it can't all be good, great. What are the adverse effects? So the common acute side effects that we see are allergic reactions, which can happen, local site reactions. Sterile abscess can happen sometimes, but it is not very common. It is, in fact, very rare. Withdrawal bleeding. Yes, this is something that we always need to warn our patients. So this is seen more in girls who come to you in the further advanced stages of TANS puberty. So stage 3, stage 4, or even after menarche, if they've come to you, their uterus has grown. So the entire thing will not shrink under the influence of GnRH. So after the first and second doses, there are chances of bleeding and spotting. However, this does not happen after the third dose. That is when the complete suppression happens. So you should always give them a warning that this can happen. And it is nothing to be worrisome because it's not usually very severe. The data shows convulsions. However, I have not come across any case report or series which have mentioned convulsions as a side effect for GnRH. I have not seen any reported cases. Slip capital femoral epiphysis also in the data. I have never seen it. Very, very few case reports have been reported of this also. So this is a small early flowchart that you can help you. If any child comes to you with early breast development, breast budding, or the appearance of axillary or pubic hair, warrants investigation. First and foremost, if there is an accelerated height, it is a clue. Advanced bone age, LHFSH, and your ultrasound. If the entire thing is in conjunction with each other, you know it is central precocious puberty, you can treat. If there is confusion between central precocious and peripheral, we should do a GnRH stimulation test. After we've ruled out hypothyroidism and adrenal causes, and then go on with the treatment depending upon the underlying cause. So the most important question that I get asked by parents is, because we are dealing with puberty, we are dealing with periods, their prime concern is, how will this affect the fertility of the child once we stop the treatment? What are the long-term side effects? So this is something that I like to answer, and there's beautiful data supporting this. In 2019-20, it got published that when treated precocious puberty in girls versus precocious girls who are not treated, the fertility outcomes were better in the treated group than versus. So it does not impair the gonadal functions when treated. So this data is extremely important. In fact, whenever parents come to my clinic, I show them this study also to show them that they can go back and read that it does not have adverse fertility outcomes. If anything, it preserves fertility and improves them in later group. So another thing is that you find online is there is additional weight gain on treatment with GnRH analog. more so with triptorelin than leuprolide. So I had also evaluated and published a paper where, done all the reviews. So on long term, the weight gain is not significant to go from obesity to overweight, a few kgs, but this is also in accordance with the pre-existing weight before treatment, the lifestyle modifications, and the eating habits. So it's not like isolated GnRH will lead you to obesity or overweight. So it is not like that. Maybe a few kilos here, and more so with triptorelin than leuprolide. Then most often you're suppressing estrogen. It is going to affect bone accruation. You are making the bones weaker. So does it slow bone mineral accrual? The answer is it may theoretically, but there has been no reports of any bone fractures. And once we withdraw these, the bone accruation goes back to normal. They regain all their muscle accruation and it does not lead to bone weakening. What you can do, in fact, is check their bone metabolic bone profile before starting and correct any deficiencies. So it does not eventually lead to any bone problems or metabolic bone problems on GnRH analogs. So the second group is a lot of times, at least to my set of is, if the child is on GnRH analog, we know their final height will be affected, compromised, and the child is not growing the basic 5 centimeters a year. Can we add growth hormone to the regime? It is an option which can be considered, but not every child who's on GnRH analog warrants growth hormone. If the child is faltering, if the bone age permits you, and the velocity is less, and there are no other underlying hormonal, you may be considered from case-to-case basis. Not every child, it is not a mandatory combination therapy that needs to be offered to every child who walks with precocious puberty. So this is again a research article which was published where a combination of GnRH and growth hormone was given, and it showed an increase in the final height, whether or not. So their data showed that the combined therapy definitely increased the final adult height in the girls by a significant. But like I said, this is not a dictum. This has to be decided case-to-case basis and titrated depending upon the final outcomes that you predict in the girl. So the GnRH's Growth Hormone Research Society 2019 guidelines came, which said that if there is a very slow height SDS, adding GnRH analogs to growth hormone therapy in short children, or especially growth hormone deficiency, or children who've been SGA who've not caught up, should be personalized according to the therapy. So this combination can be given, but on a case-to-case basis. SGA babies, small for gestational, is another particularly sensitive topic for me because they get missed very often. Because once they're 2 to 3 years, people forget that they were in SGA. These children have a whole lot of endocrine disorders associated with them, which continue throughout their adolescence and adulthood. So there is a higher risk of early puberty in these children. There is some amount of height lagging which happens. And there is evidence that treating them for precocious puberty and adding growth hormone definitely has improved outcomes in final adult height. These girls are also at risk for PCOD later. So SGA babies are a set of children who need to be followed up from their birth to their adulthood. So the transition from me to you will also happen in these girls because they will end up with you for fertility problems and PCOD. So the underlying cause would be because they were a SGA child. So again, the evidence for growth hormone in SGA, which was good. The treatment was mainly to increase the final height, to increase the adult height in children, suppress puberty. The results in central precocious puberty was good. So the take-home message here is there is a shift in the demographic, in the appearance of secondary sexual characteristics in boys and girls. But early onset of puberty is not the new normal. It warrants investigations, and in cases where it's required, it warrants treatment. So that's all for the topic for today. I think I will like to stop it here. And Dr. Ritu, ma'am,
Yes,
you can.
thank you so much, Dr. Sweta. It has been wonderful and very informative talk. Now I invite the experts to please give their valuable inputs.
So can I come first?
Yes, ma'am, definitely.
Now you can see me. I think my camera is working.
Yeah.
Well, wonderfully done, Dr. Smita. You have made us revise this topic. I must admit, as a teacher, it was a very small note, like precocious puberty in undergraduates, maybe for 5 marks. And even if somebody had written a definition and a few things, we would have given 2.5 marks out of 5. For PGs, it used to be once in a year class, and very seldom we were getting the cases in the OPD. What we were getting were walking dwarfs, whom we used to call walking cesareans. And straight away we would decide it is going to be a cesarean without going into the cause of it. Now, today you made me read again the whole topic, and I revised, and it is much more advanced. What you not said, but I would like to say, do we go for genetic testing? I read this gene, ACAN gene mutations, and they said there's so many phenotypes. And then these phenotypes make you have the clinical differences. Somebody may be having everything grown, somebody may be having more of thelarchy, more of menarche, more of pubarchy, and all that. So how much is the genetic thing added on to your investigation?
Okay, thank you, ma'am. So genetics has grown in leaps and bounds. But again, ma'am, genetics is very expensive. And you have to weigh that if it is extremely precocious. So less than 6 years is when we warrant an MRI to rule out pituitary causes. But even if you have a genetic lesion, which does not alter your treatment course, how will your genetics help you? Unless there's a whole conglomeration of symptoms associated with it, we don't usually do genetics for isolated, simple progressive puberty. Of course, a very short girl with very early puberty, when you know it is more than a mixed symptom, then of course maybe, but not on a regular basis, not for isolated central precocious puberty.
Let it be for academic reasons only. Somebody is interested, or endocrinologists are doing it.
And we do it, ma'am, when, like I said, it is associated with more than one symptoms. We feel it is not a simple isolated precocious puberty. It is a part of something else with severe short stature, then we might, but not just for isolated cases.
So one thing what I have seen is, the girl coming like this, I look at the mother and the father, how tall they are. So it could be a constitutional. It could be a smaller variant of the normal, means towards the low range. So when do we start like following from 6 onwards or 8 onwards for pathological precocious?
Ma'am, beyond 6 years, every girl, every child, boy or girl, beyond 6 years should be done a pubertal assessment. Tanner staging should be done. It's easier in girls because you don't need any great equipment. Boys, you still need an oxidometer. You need your measuring for your penile length. Girls, all you have to look is thelarchy, axillary pubic hair. So it's very easy. But the dictum is beyond 6 years, every child who walks into the clinic, boy or girl, should be evaluated for secondary sexual characteristics.
So what I get it, what you said, mother has to be a keen observant for a quick height. So she is the one who will bring the person first of all. Otherwise, we will not be knowing the things.
She is the one who will pick up the fact that thelarchy has happened and sit on it and not do anything about it because she feels abhi to shuru hua hai, bahut saal pade hain. But the point is from start to end, it is just about 1.5, 2 years. So we don't have so many years.
The last point which I had was related to the reproductive counseling, which you have clarified. Only thing is, can she marry a person of a normal height and have a progeny of an average?
Ma'am, again, the formula is that we use. She can, but the effect of her height is what we will calculate of what her height is, right?
Yes.
If she has remained short, so the calculations and it will not be adequate. So we will not be doing it correct. It's mathematics. But if your first variable is wrong, then your final product is definitely not going to be correct. So yes, that is an option. I have married somebody who's 6 foot, hoping I'm going to have a tall daughter, but time will only tell.
I will only tell. So you cannot predict actually. No. Thank you so much. It was wonderful and I really enjoyed it.
Thank you so much.
Thank you so much. Dr. Ritu, you can take up.
Ma'am, any other expert?
Yes, Dr.
Yeah.
Ritu.
Yeah.
Thank you, Dr. Ritu, Dr. Sadhna, Dr. Sharda, and all seniors for a choosing such a beautiful topic, which is rarely discussed but very important. And Dr. Smita Ramchandran has done really a good justice to it. And as very rightly said just now before me, that we have revised it. Precocious puberty, I think, is one topic which needs multiple revisions. And the one reason is because as gynecologists, we are not daily commonly seeing these patients, rarely do come. And here I would like to say, once in a while, because the patient comes, this topic was further important because we initially, all of us, including I would say me also a few years back, then I actually read about precocious puberty. When this patient comes, so when the mother walks with the children with this complaint, you just say, okay, we'll see, and let us observe. And initially, you are not very clear about it. So that's a very important thing, that all gynecologists should be aware of the basics, at least. Of course, the management is of the pediatric endocrinologist. We should always, whatever we should do, should be in their collaboration, and the proper investigation should be done, and patient should be under their care, managed. That's what I feel. But basically the mother will come to all of us, and there we should have this much knowledge that we can refer the patient to the right person. And you can see now very clearly, these days the puberty has become early. So before 8, if it starts, there we have to be careful. Patients do not come to us at 6 years of age of the child, that we can observe and continue monitoring. They will come once it has happened, something like thelarchy, they will come. And there we have to remember that sometimes isolated thelarchy or isolated puberty are also the entities which have to be observed. So their observation comes, and of course you have to tell the patient that what all are important things to be observed and to be taken care, that this can happen, and the importance of this, that the height is the most important thing. If once the menarche, and this much I think even common person understands, that once the menarche is there, then the height of the girl will not increase so exactly to the optimum time. This somehow even the laymen do understand. So we should take the advantage of this fact and guide them, so to get investigated, that what is the bone age, what is this, and let it be differentiate. Because once I know I had a case, and that was a very eye opener for me, that there just got a simple investigation done. The thyroid level came into hundreds. And when I just managed that thyroid level control, everything came into control. So the peripheral cause and the central cause, as Dr. Smita has very beautifully described, even the flow chart has given, can be different, should be differentiated, and accordingly, then patient should be managed with definitely under the guidance of pediatric endocrinologist. That's what I just want to give message, that we should not let it go, that ऐसा हो जाता है कभी कभी jaldi and all that, we layman excuses. We have to guide them to a proper person and make them counsel and investigate them. That's what I just want to give the message to general everybody of us.
Thank you very much, ma'am.
Thank you, Dr. Ritu, and
I
thank you,
hope
Dr. Sadhna.
Dr.
Again.
Chandan
Yes.
is
Thank you,
with us.
Dr. Sadhna. Thank you, Dr.
Dr.
Ritu.
Chandan Kachu,
Dr.
she's
Chandan Kachu, please.
yeah, she's joined. Yeah, madam.
Thank you so much, Dr. Sadhna, for inviting me. And Dr. Ritu, thank you so much. I have only 2 points to make. One is I wanted to ask question to Dr. Smita. Dr. Smita, you have done a wonderful job and beautiful presentation. I just want to ask you, is sexual behavior something got to do with the precocious puberty? These days, we see a lot of sexuality issues which are happening in early puberty, so the people from 4th standard, 5th standard have started having relationship issues. Is it has some relationship with the precocious puberty?
Ma'am, with onset of central precocious puberty, the hormones which are affected, so behavioral changes, so adolescent temper tantrums, behavior, those things happen. That is correlated with puberty, because when we treat them and we suppress the LHF estradiol, you feel the parents see the difference. The tantrums go down, the anger issues go down, the behavioral changes go down. So those, of course, are attributed to puberty. But the thing that you're saying, these precocious, non-pubertal children also, this is just exposure, the kind of exposure they have, the kind of access they
Yeah.
have to a
Yeah.
lot of things.
So
Yes.
where is the line? And there should be a certain line where we can suspect that.
Ma'am, it
Is
is,
it,
yeah. So
yeah.
like I said, with the onset of any secondary sexual characteristics, so in boys, the first thing is
So we have to correlate the physical as well as the mental
yes,
behavior.
yes. So if without examination, a height spurt is the first big sign that will give you a telltale sign. Any axillary pubic hair onset or thelarchy in girls, or axillary pubic hair or testicular volume in boys are the first initial signs of secondary. So you know their puberty is somewhere around the corner. It's just starting. So you can expect a certain change in their behavior. Yes.
So we, because one of my friends who is a psychologist had seen one patient, and when we examined, she turned out to be a precocious puberty patient. Yeah. Then another question was, what are the infertility problems? What do we expect? Because I have a patient who had precocious puberty. How do I counsel her for the infertility part of it? What problems?
Puberty by itself, like I said, the data is when treated versus non-treated, the fertility.
He was not.
So
just
also,
homeopathic ilaj.
Also, so the fertility gets reduced. Also, they're also at a higher risk for PCOS because of early activation of the hypothalamic pituitary axis. So these are two things which, so treatment does not alter the risk factors or the occurrence of PCOS. There is no change on the effect of that, but fertility improves. So PCOS is one problem that they can encounter. Fertility, reduced fertility is something again they can encounter. But once they've crossed that stage, you cannot go back and correct it. So what is going to happen is you'll have to deal with it as it comes on. Before, if you've not acted on it, yes. So, but PCOS does not, the risk factor does not alter with or without treatment. Fertility treatments become better.
Thank you so much for clearing that. And I think your last take-home message was the best message from this presentation. That behavior has changed, but that doesn't mean precocious puberty does remain the same. Thank you so much for a wonderful presentation.
Thank you very much. Thank you very much.
Just one question. What about the endocrine disruptors? They have an important role in early puberty. So if we can we remove it, or can we do something about it?
Ma'am, there have been couple of postulates. In fact, one of the recent articles published last year or something, that with excessive use of sanitizers, one of the chemicals in it has been an endocrine disruptor. But the data from these studies is very limited to generalize them. So you cannot say so we don't know if it's a cause effect or a whole Pandora of obesity, less activity, junk food, which has led to obesity induced early puberty, or sanitizer, because all this happened around the same time. So we don't know the cause effect association as yet. But small studies, individual case reports have been there. But endocrine disruptors, definitely, specifically, we've seen is a lot of Ayurvedic products with tea tree, lavender. These things lead to an increase in estrogen. So when we, like isolated estrogen levels high, everything done. Couldn't find a cyst, couldn't find a tumor, couldn't find everything. Dig. Then a lavender oil preparation. Stop that. Within 3 months, the estrogen levels fall. So a few of these things we have seen, but again, these are individual case reports. When we group of endocrinology, we discuss in our conferences. So these things come up. So we now know that TT, a lavender oil, or certain homeopathic products can lead to isolated increase in estrogen. But then it won't be central precocious. It will be only isolated peripheral estrogen rise. So these are a few what we call endocrine disruptors, which have seem to be affecting sometimes.
I think we should know more about these Ayurvedic drug preparations or homeopathic, which do produce these, because many of times patients are taking homeopathic or Ayurvedic treatment and we are totally ignorant about them.
So the bulk.
I think we are aware of, Kiranji, you have put, Smita have put that one Kerala doctor have put now public interest litigation, and that Pantajali people have to give the written apology for it. And we were really thinking since a long time when we come that how can anybody claim such an unscientific thing and nobody is objecting. And I said, somebody has to take that courage, and that is going to change.
I just heard about it. But the thing is this, हम लोग जो छोटे छोटे daily लोग लेते रहते हैं, we don't know what they are doing.
Yes.
Many patients with precocious puberty, ma'am, take homeopathic medicines. Even in my family, they took.
Everywhere.
So, Ritu, we can go for the reverse panel. We request
ma'am.
our Smita, you will be there. We have so that will be the reverse panel. You have to be there along with our all experts. So, Ritu.
Yes, ma'am. Now we come on to an interesting session, that is reverse panel on precocious puberty. Moderator is none other than Dr. Sadhana Gupta, madam. She is President NIGF, and she is Senior Consultant and Infertility Specialist and has held innumerable positions in Foxy. Welcome, ma'am. And our panelists are Dr. Archana Singh. Pranjal, can I have the CV of Dr. Archana? Pranjal?
Just a minute.
Yeah.
Yes, ma'am.
Yeah, she is Director, Siddhi Vinayak Hospital, Haldwani. She is Secretary, the State Secretary, NIGF, and Secretary, Uttarakhand Society, and Scientific Secretary, IMA, Haldwani. Welcome, Dr. Archana. Dr. Archana, are you there?
Yes, ma'am.
Okay. Welcome. Dr. Sarika Gautam. She is Professor, Obs Gynae, PGIMS, Rohtak, Haryana. She is a member of National Medical Council and has received many awards at NIGF and has more than 14 international publications. Welcome, Dr. Sarika.
Thank you so much, ma'am. Yeah.
And third is myself, Dr. Ritu. Yes, ma'am, over to you now, Dr. Sadhana.
One of our panel, and please stop slideshare. And Ritu is from our own city and a very systemic and a very organized person, and we always can bank for any responsibility to her. So welcome Archana, Sarika, and Ritu and Smita for a beautiful talk. So one thing what we say, the hormones is something always elusive. We say that like it was a classical teaching, they are produced in certain hormone, and it is a what we say na, jo hum logo ki, it is a North India Gynae Forum ki jo स्मृतिवान लोग होते हैं वो कोई रास्ता नहीं छोड़ते मछलियों और चिड़ियों की तरह. Hormones, since I was a biology student, it really I got totally fascinated by that the thyroid hormone which is produced in that and how it affects every system and everything. And today our understanding about hormone is much more. Actually, what we said that it is a hormone, yes, it is a very simple voyage. It has become a very complex travel because a gland might be secreting hormone, but the tissue which it is supposed to reach, it can have receptivity or it cannot have receptivity. So it is something about a very complex coding of communication which affect, and we are always troubled that tall parents have a short child and the short parents have a totally normal, and where they get that genes and hormones and nutrition. So sometimes the life sets to you a very difficult situation, and precocious puberty is one of that situation that we are sometimes totally at loss. What is the difference between normal or abnormal? Are we losing time? That we could have done something better for that child, and we really lost the time because already the bone age has been, all epiphyses have been fused. So I will have my own few questions and some experience. Before that, I will invite Archana, Sarika, and Ritu to share your question and your experience as well as your comment about the thing. So we will start from Himalaya, Uttarakhand. Archana, your experience about short stature and all precocious puberty and your input about it.
Ma'am, my first patient on precocious puberty was a girl. She was 8 years old And when she came to me, she already had started her menstrual cycle. So at that time, I was not well aware of precocious puberty, and I had to refer that patient further. Even I was not able to, tell her how to evaluate and how to go further. So from that time, this was my subject which I would like to, get more and more learn about it. Ma'am, I will start with the basic question with you. So, when to suspect precocious puberty and how to evaluate a case of suspected precocious puberty?
Ma'am, you want me to take the question?
Yes,
Okay.
you are
Blow me away.
So, Dr. Ritu, like I said, beyond 6 years, any child who walks in should be evaluated for secondary sexual characteristics should be done, TANF staging. Any child, any girl or boy who comes with axillary hair, pubic hair, or breast budding, there is a chance it is puberty, that it is going to progress. You have isolated variants. It can be an isolated puberty, thalaki, but it is puberty unless proven otherwise. So the basic first thing is, has there been a height spurt? It will be evident from the history the mother gives. It will be evident from the growth chart. Second thing, get a bone age done. A bone age advancement more than 10% of the chronological age is also an indicator if it's puberty or not. The caveat here is obese children. In obese children also, the bone age may be advanced. Third, of course, the LHFSH estradiol done at a specific time. Again, the problem here is the spurts in which LHFSH is raised. So if you have an advanced bone age, height spurt, but your LHFSH is low, then do a GnRH stimulation. So when in doubt, do a GnRH stimulation test. It is the gold standard. If that is positive, the hormones are high, then it is central precocious puberty. It needs to be treated. But if your LH is also high, your bone age is all advanced, you've got your physical features, you can start your treatment.
Dr. Smita, you have been mentioning the age above 6 years. If the child is below 6 years,
so, ma'am, below 6, see, above 6 years is when every child should be evaluated. Any child who comes to you with these features less than 8 years, the youngest I have treated is a 3-year-old boy with central precocious puberty. So any child who comes with these symptoms anytime, but our normal age where pediatricians start examining for secondary sexual characteristics, 6 years onwards, it's in the recommendation. But before that, anytime any one of these 3 symptoms are there, it warrants an investigation in any child less than 3 years, irrespective of the lowest age.
So if we say one investigation, the main investigation, then it has to be the bone age?
To suspect. If the bone age is not advanced, you can still wait and watch.
And what about the TSH? TSH should be done in every patient or only in the retarded ones?
So, ma'am, again, TSH is, if it is TSH is so prolonged to cause early puberty, then auxology, that means height, weight, would have been affected. In a child who's growing well enough, tall and good for parental height and not lagging, my suspicion of TSH will be lesser because TSH has to be prolonged. See, the receptors of TSH and LH have similar biomolecular structure. That's how very high TSH results in puberty, because they act on the same receptor in the hypothalamus. But the duration and the values have to be long enough to cause the effect. So by then, the child would have got stunted, had features of hypothyroidism also. It's very unlikely a high hypothyroidism will only present with pubertal precocity and not any of the other symptoms. But as a first line of treatment, you should always rule out hypothyroidism.
Archana, what we say now. So I remember one girl with around 5 or 6 years. So that is a sign of precocious puberty, and a simple ultrasound. Like two things what I'm like mixing Ritu and your that ultrasound, and that was a ovarian neoplasm. So that was a peripheral puberty. So that take like, and the thyroid estimation. One thing I will say before we go to Sarika, Chandan also said about this thing. So thyroid issue is the thing, Ritu, where we cannot actually go away from it, whether it is a tiredness, whether it is a low performance in the school. That the thyroid is in Asian community, it is diabetes and thyroid, autoimmune, two disorder go hand in hand. Prevalence is too much, and the treatment of thyroid disorder is so easy. So I have one gut जो दोनों का combination चंदन ने कहा और रितु ने, just 1 or 2 months ago, the girl came at like it was 8 year, almost 7-8 years. So they were very frightened. So she had bleeding. उन्होंने कहा कि because of itching she had bleeding, but 2 or 3 gynae has refused that it is a rape case. So I examined her. She was a puffy face, not looking like very like not drawn. What we see in a hypothyroidism, लेकिन उसको थोड़ा सा था trauma and bleeding. So nobody have examined and everybody was frightened. तो वो किसी neighborhood के संग में आई. तो that was the thing. We gave supportive treatment and her TSH was around 21-22. So I give just symptomatic treatment. Everything was fine. The important thing, Smita, with this is the two-way, actually. When the baby has the, so thyroid estimation, I can say that we cannot omit in like any patient like this. So thyroid, we must have, it is a very like a cheap test and the treatment is very cheap. What we say, it is two-way, what you say. If the girl get precocious puberty, because she is the more chance for getting like something like the exposed to the sexual offenses. What in our country, a very strong POXO Act, and I was really sometimes POXO, that life gives you such a difficult situation. I was also suspecting in this gut, kuch ho bhi sakta hai, but I could not dare to like inform police or something, and they were so afraid. Nobody was catering, and we could detect the thyroid or something. And we also, I say that be careful about the child. So what you say that when, yes, of course, the Chandan says that the exposure to what we said, the social media, everything is exposed, pornography and whatnot. It is, life has become very wide. But when the child gets that precocious puberty, she is more liable to get something like such offenses right from, and that should be the part of counseling. So what is you, with your wide experience, what's your takeaway about that?
Ma'am, like you said, there is no doing away with thyroid. It is one of the cheapest tests. It is one of the cheapest to treat. It is reversible. But yes, like you said, see, a girl who gets precocity at 8 years, she does not understand the implications of it. She will not, a lot of times, even understand that if a sexual offense has happened to her. So they are not mentally mature. So it becomes the burden of treating and counseling doubles up, ma'am. Because most likely the child will come to a gynecologist and a pediatrician, let alone a pediatric endocrinologist. So the burden of ascertaining whether she's had a sexual offense coupled with precocity is a double-edged sword. You have to manage both. So it is a very, very tricky thing to do. But counseling the parents becomes extremely important then, because the child may not be self-aware of it. She will not understand what getting period translates to. Right? For her, it is just something bad which is happening, but the repercussion she will know. So the onus of explaining and managing falls on you to the parents. So it's a very, very difficult and tricky situation, ma'am. And the kind of population we cater to, a lot of time it doesn't get picked up. It is a social stigma. So they will not even come up and tell you, even if they know the history. So it's very tricky, ma'am. You have to be, so hence again, precocity is a bigger challenge.
I would like to refer a case, Pam, here. I had a case, the family had come for the LSCS few years back, and their elder child, who was a male, he was about, I think, 6 to 7 years old. And the grandmother landed to my chamber and she said that he has got some very embarrassing, he used to do some very embarrassing behavior he was showing. So the like adults would do and all that. So I just noticed, and that benign enlargement was there. So I referred that patient to the pediatrician, and then I traced it that what happened to the child. So they got the MRI done, and hematoma was found over there. So these social behaviors are also to be judged or seen.
Yes, ma'am. So like you said, like the youngest case I told you, the 3-year-old was a hypothalamic hematoma. Hypothalamic hematoma is the commonest cause of precocious puberty a lot of times and mostly seen in boys. So any boy with this kind of behavior, doing abnormal fiddling of his genitals, increase in his genital size, having morning erections and all, warrants evaluation. Because like, so another group of children who need to be evaluated are, ma'am, the autistic spectrum or mentally challenged children, because they do this in public, they do this in school,
Yeah.
then they get ostracized, then they get sent back, the parents don't know what has happened. So if you're not aware that you need to treat precocity, these children are generally precocious in puberty because any CNS condition can result in precocity. So I
But the
have
height was normal for his age.
Ma'am, height was normal because probably he has had a height spurt. He could have been taller also.
Okay.
So with puberty, the happy thing for parents is they're growing very tall, but the final height gets affected. So they will be normal or higher for height at presentation with precocity.
Dr. Smita, can we correlate physical inactivity in nowadays children? They are quite physically inactive. Can we correlate precocious puberty with this?
One thought process that is evolving worldwide is the change in demographics in terms of precocity, puberty, early puberty, not precocity in itself. Inactivity, weight gain. Weight gain is an independent risk factor for early puberty. So inactivity contributes to that by simply lowering metabolism. So it is, like a risk factor for the risk factor. So yes, definitely, if this leads to weight gain, it will be a risk factor for early puberty, because obesity definitely is. Why? Obesity is also a risk factor because it causes bone age advancement. So the physiology is interrelated. Early body maturity can lead to puberty.
When should we treat a girl if she's already having menarche? So if she's
So if the girl is less than 8 years, irrespective of her bone age, you can treat her. If the girl is between 8 to 9 years, so you have to realize that menarche is the last stage of puberty. If she's had menarche, that means her secondary sexual characteristics started 1.5 years. So if it's a 9.5-year-old girl who's come to you with periods, her puberty started at 7.5. So she's precocious. She's not presented to you at the precocious age, but her puberty started. So if there is adequate bone spaces left for bone growth to happen, so from the height point of view, that is your marker to treat. Age point of view, a 9.5-year-old girl or a 9-year-old girl with menarche is also precocious. You can treat for a good 1.5 year till 10.5 years. But if the puberty changes start after 9, then by definition, they're not precocious or early. So
I have a girl who was around 6 years. She presented with isolated thalaki. So I should say the pediatric endocrinologist, they followed her up for a period of about 2 years. And she was a slowly progressive type of patient. And at the age of 8 years, they found that the bone age was 11 years. So now they have started with gonadotropin agonist.
So, yes. So, ma'am, that is one of the conditions, like I said. If the height spurt hasn't happened, if the bone age advancement is not there, these are indicators that the progression might be slow. Because if the progression is fast, your bone age will be advanced. Your height spurt may or may not come, but your bone age will be definitely. So if it's a very slow progressive, sometimes isolated thalarchy does not progress to CPP. It is just an isolated thalarchy. So if your LH and FSH have not risen, that means she is not in CPP. You do not treat her for analogs. What will the analog suppress if the hormones are? So, but isolated thalarchy can change to CPP over the course of time. Hence, the follow-up needs to be done. You have to pick up the time when it converts to CPP.
So when will we label these patients as rapidly progressive ones, and how often should they be investigated?
Rapidly progressing is when the bone age is more than 10% or the height spurt has happened at the time of presentation. That means they're already rapidly progressive. Otherwise, if the bone age and height spurt hasn't happened, the bone age is appropriate for age, at least every 3 months, physical examination should be done. Physical examination, if your Tanner staging changes, evaluate with biochemical tests.
In cases of complete precocious puberty, which marker like bone age should be taken, whether we have to observe or we have to go in depth treating that patient?
Ma'am, first and foremost, your tanner staging. If your physical tanner is not progressing fast, then you don't need to subject the child to bone age, because every 3 months the bone age will not change substantially. So there should be at least a minimum gap of 6 months for changing your bone age. So physical examination is a prime marker. Any progression of your thalaki, pubarchy from one stage to the other faster, like if you're examining in 3 months and the stage has changed, that means the progression is fast. That warrants evaluation. Otherwise, on physical evaluation, if you feel the child has not progressed physically, you can easily wait and watch.
So is MRI essential for all the patients?
Before
Or
we
should...
go, I think
MRI,
we will sum up 1 or 2 points which Smita have raised. So Archana and Ritu, what we like from Smita's deliberation, that when we have got the isolated thing, it is 2 things. कभी क्या है कि gynecologist से नहीं नहीं कोई बात नहीं, it happens, अब तुम कोई चिंता की बात नहीं, so they forget कि डॉक्टर ने कहा है. We have to be very pertinent about it, that at this moment you might not need the investigation or something after doing everything, but the girl need to like be called again after 3 months or 6 months, because we cannot say. So हमेशा लोग जो patient होते हैं ना, वो सोचते हैं कि हमको कोई मतलब medicine देंगे and the things will go, और ये abnormal है या नहीं है. And we actually only the time will say that this thing is normal range, or the child is crossing normal age. So this one message what I brought up, like picked up from the Smita's and the Ritu's and the Archana's question, that yes, we get isolated hierarchy, but it is not a one time or 1 point question. We have to say आपको देखना, और 3 से 6 महीने के बाद आप फिर आइएगा कि अगर उसको कोई प्रॉब्लम होती है. Can you suggest, Smita, that there are we can say very clearly, जैसे what we say ना in everything, क्या अलार्म साइन है कि अगर उसको ऐसा होता है तो आप हमारे पास जरूर आइएगा.
So, ma'am, what I tell every
So
mother,
long, after that we will come to you, Sanika. Yes, Smita.
what I always tell is, अगर if it is unilateral thalaki, अगर छाती में दर्द दोनों तरफ होता है, छाती बढ़नी शुरू होती है, छाती दिखनी शुरू होती है, या बगल में बाल आना शुरू होता है, या नीचे की तरफ बाल आना, if it started, अगर वो घना हो जाता है तो वापस आइए. This is clear cut. The mother will know. She will pick it up. You show her what your findings are. So whenever I'm examining, I always examine the mother with me so that she knows what are my findings. She will know when it changes, because usually these kids are given bath by the mother, or the mother will change her clothes. She will know. So these 3 points are enough for the mother to come back to you.
Follow-up should be 3 monthly or what?
Yes, initially 3 monthly, ma'am, because you don't know the rate of progression yourself. So the first 2 visits 3 monthly, then you'll know. You can call them after 4 months or 6 months, but first visit, it's better. There is no definitive guideline, but yes, I've seen in my practice 3 monthly follow-up in the beginning is better.
A very good evening. Actually, I want to share my experience that I have received a girl of 8 years. She was having obesity and short stature. Along with, she was showing Tanner stage 3 of breast, and since she was showing some spotting, so she was referred to me from the pediatrician side for the general examination. So I have examined her. There was no any sign of estrogenization and anything. So I would like to ask how to proceed for these cases, that she was obese, she was short stature, and she was showing these signs of estrogenization, non-estrogenization. So how I have to proceed for these cases?
Ma'am, this is an endocrinologist's dream case. So any overweight child who's short stature is a straight arrow that it's an endocrine cause, because obesity is usually associated with a growth height. So any child who's overweight and short has definitely some endocrine. The top of my chart would be a thyroid. Hypothyroidism would be the first on my list of things. Second would also be an adrenal cause, a CAH or something, or a hypercortisolism. These are the first 1, 2, 3 I would like to rule out in an overweight short child. Having said so, even if you've not had features of estronization, an LHFSH basal is warranted irrespective of the physical findings. Ultrasound of the uterus, ovaries, like the volumes, like I said, they're also helpful. So uterine
What
length.
exactly we have to see in the USG findings?
So ultrasound में uterine length more than 35 mm, non-tubular uterus and ovarian volumes more than 2 cc are prepubertal, not prepubertal. These are pubertal values.
Okay, and what about the ovarian cyst? How much size is significant for that?
Ovarian cyst sizes is not significant.
Not
It
big.
is the
Okay.
hormonal reflection. If your estrogen values are high, then it is important.
Okay, so should I go for the serum FSH, LH as well, or the only
Yes.
TSH?
How will you know whether it is central or so you've done a TSH. If your TSH comes back normal, then what? So
Yeah.
LHFS is your first line to rule out central and peripheral. So
Yeah.
So
Okay.
which would be the most important marker test in this case? Should we go for LH? Like,
LH. So ma'am, if it is only one test that I would do a TSH and an LH.
So, ma'am, how much LH level
And an
we should,
estrogen also, because estrogen, I need to know what the values of estrogen are. If the estrogen is very high in relation to LH, then I'll look for a cyst or some other cause.
If the ultrasound findings are normal, then can we see the vaginal mucosa and interpret that there is estrogenization or not?
I do
Yes,
not
no,
know how to
that
interpret a vaginal
that
mucosa,
I
ma'am.
have
I will
seen in
not be
that
able to
girl.
tell you.
So,
yeah.
My
so, ma'am, we have
expertise is almost zero in identifying vaginal mucosal estronization. I would love to learn it from
vaginal
you.
Rachna,
mucosa
that is
is
psychologically traumatizing. Actually, this is one thing that we should never forget that we are dealing with child, and every experience in the childhood gets a long-term memory. So if it is a reassuring, supportive, confidence building, क्योंकि कई बार parents भी, like
They
in
will
India
not
we
come
say
back.
ना, the parents are not confidence building. वो हमेशा मतलब ना, they complain about their child and they are very anxious. That cause the indirect message कि पता नहीं मुझे क्या हो गया. So this is something very important that we give full time, and in all adult gynae world that child is lost. So this is something very important, and I think with a good ultrasound, Archana, I don't think that we need to have any
Ma'am, but I
examination.
think we have to look for the Tanner staging of the
Tanner
pubic
staging.
hair,
Yes,
and then we
Yeah.
have to look for the clitoral hypertrophy or not.
that is fine, but vaginal mucosa, that includes the separation of labia and then looking. So if it is comfortable, you need, then you can do. But just I say that environment, like we are very busy. Sometimes we are already occupied. We must differentiate that
That's
class
traumatic
of
for the
which you are
child,
in.
definitely, ma'am.
It's very, yes.
Another question is how to deal the cases of isolated pubarchy. Like one girl came to me, she was having only Tanner stage 2 type of pubarchy, and other she was not having axillary hair along with it. She was having only in the pubic area, and she was very concerned about that. She's having bad odor also along with some vaginal discharge. For the vaginal discharge, I have given the treatment, but she was asking for that. Uh, so how to proceed for the
So,
isolated
ma'am,
pubarchy?
isolated pubic hair, one of the causes could be adrenal causes. So, if you've ruled out adrenal causes, there is no excessive adrenal hormones can also lead to pubic hair growth. Once you've ruled out that, there is nothing much to be done for it. The life
Okay.
cycle of the hair, which has already come, will take its own path. There is nothing you can do.
Okay.
Even if it's a
And
CPP, you
yeah,
can't do anything for that.
in the same girl, but she hasn't attained the menarche, but she showed that PCO features which you have told in your session also. So, should we treat that PCO feature? Yeah, we have to just follow
Ma'am,
these
how
cases.
old? No, ma'am. PCO
She was
features.
9 year old. She was just 9 year old in between, not precautious exactly. We can say what.
But ma'am, 9-year-old will not have PCO features, na? She will only have a risk for
See,
PCOS.
cyst थे, मतलब it was not like proper
Actually,
PCO
what
feature.
Sarika, here I will like to comment that
Yeah.
ultrasound is not advised for diagnosis of PCOS until 8 years after menarche. AMH is not advised for diagnosis of PCOS. And we will have one session. Adolescent PCOS have a totally different criteria from the adult. And the third thing, and why it is not, because it is always suboptimal ultrasound. We are always doing abdominal. We cannot say differentiate between a normal follicular development and what is called the PCOS. And it is a very sad affair that so many ultrasonologists on the pick of whatever they find in ultrasound, they will say it is cystic ovaries and it is polycystic. And actually, we have to say so many times it is just follicles. They are not cyst. Even then, even so, ultrasound is not indicated till 8 years after menarche for the PCOS. Precocious puberty, when we like to rule out what are the uterus size, what is the ovary size, it is visible or not visible, and at the same time, it is always better that we do the focus on the adrenals also, what is happening on adrenal ultrasound. So in precocious puberty, our aims are different for ultrasound, but for precocious puberty, actually it is not in the diagnostic tool. If Smita, you add to what I
You're
have said.
absolutely right, ma'am, because we have done away with ultrasound as diagnosing for PCOS because the overlap is so much, and the normal adolescent physiology will have multiple follicles which get misdiagnosed as cyst, and cyst count is not taken as a diagnosis for PCOS in adolescents anymore. So the follicles reported as cysts don't hold any value at all. It's normal adolescent maturity which happens. So follicles / cysts should not be taken as PCOS to make a diagnosis in the adolescent group. Not at all, ma'am. The criterias we've changed, the definitions have changed. Like ma'am, you rightly said, AMH and ultrasound are not used anymore.
Dr. Smita, how much is GnRH analog helpful once the epiphyseal fusion has taken place?
They will not help, ma'am. They will not unfuse anything. Whatever has fused has fused. Whatever has not fused, it will delay.
Height will not increase, even
If
by
the
some
epiphyses
centimeters.
No, ma'am. So it depends upon if it is all your phalanges have fused, then of course you will not. Only some spinal spaces, few centimeters. GnRH analogs will not help once the bones have fused. No, ma'am. Even growth hormone will not help if the phalanges are fused, ma'am. If your epiphyses fused, none of the things will help.
So one thing in your presentation, you says na addition of growth hormone and the GnRH analog. So GnRH analog is something not very tedious thing. It is once a month, so it is okay. And the growth hormone is the daily thing. So it is a very difficult situation to add on the both things. So your experience about that.
So ma'am, like I said, it is not the first thing I offer, but if the height velocity, so we know the problem is we all know that because of the bone age advancement, their final adult height is compromised somewhere. When you follow these girls and they're not even getting their 5 centimeters a year, and you know that by 10 and a half, 11 and a half at the most, you're going to stop the treatment and they're nowhere near, then you add growth hormone. The thing with growth hormone is, ma'am, it's virtually painless. The needles are insulin needles. It's once a day. I have not, of the number of kids I've treated with growth hormone for GHD or GnRH, I've not had a single dropout because of the process of injecting. You do it at night before sleeping. It is virtually painless. So it does not matter. Now we've come out with weekly growth hormones also. So the daily pricks have been done away. It's of course much, much more expensive and all those things, but that is also an option now. But when the parents see, so the parents know we've already suppressed puberty, at least height to badh jaye. So they're very sensitive to it, ma'am. So a lot of them, in fact, ask me to start growth hormone because they've done their research so that they can attain. They want to take maximum benefit out of this 2 years because anyway, they're suppressing puberty. So they want to attain the height. So the ones who are faltering, definitely I suggest growth hormone if it is indicated the bone space is allowed.
Thank you. This is something very, very important to know. Ajay, one thing, what we say, the GnRH analog for so many things, for endometriosis, for so many things. If the child height is okay, like with their family and something, can the DIMPA be the cheaper, poor alternative for GnRH analog? DIMPA, like we say in some mentally retarded girl who are having menstruation, and sometimes the people come for hysterectomy even. So DIMPA, poor alternative for many drug we are considering. Can it is be of help in somewhere in the management of precocious puberty?
Children with learning disabilities and behavioral disabilities, I have not given DIMPA. I put them on the depot preparation and they go on for years. So, so we have 22.5. So very selective population we use it because we can't titrate the doses there. Because a 6-month depot becomes difficult to titrate if the pubertal changes happen or the hormone lesses. So we take them on GnRH only, ma'am, because it's not very expensive. When it comes to 10 weekly injections, it's not very expensive. So these children also with behavioral and developmental problems, we take them on one of the GnRH analogs for a longer time.
So something which is, this is important. It is a little bit outside topic, but so many times in our group, we say that the parents are coming for the hysterectomy, then we have the like a more humane alternative. And it is a very painful, if any surgeon like does it, it is something the surgeon will never like to remember. It is very, very difficult and a painful situation, and we have the alternative. So one very important message we wish to give that, and it is not 4 weekly, it is not monthly. You are saying na 8 to 10 weeks.
Ma'am, the depot preparation, there are two separate depots. One is monthly, one is 8 to 10 weekly. So the 10 weekly for those work, ma'am. So once in 2.5 months, what, 4 or 5 injections in a year. So it
is okay. So some very important message to everyone that like medicine, finally, it has to be effective and it has to be always very humane. And like we say that the parents are anxious and something, but actually the society is like that. Like when I was young, I was child, every child was included in, be it a very like a little bit less IQ, less body looking, whatever. So once upon a time, our society was very inclusive. We have no difference ki kaun hoshyar padhne mein, kaun kaisa hai dekhne mein. But today the society is somehow like we have to be very concerned. It is very, very competitive, which should not have been. What we say even in the short stature that like sometimes they don't need treatment, but what to say, the society has been made like that. So as a doctor, we should not say कि नहीं नहीं वो आपके concern कुछ नहीं, अब बिना ही बात के लोग चिंता करते हैं, because it is in our environment and we have to be. And one thing about two things what we can say for the PCOS, Sarika, I put about like the issue of PCOS. For the PCOS and as well as the precocious puberty, that the pre-pubertal weight gain. So they don't, parents do come to us कि ये चाप क्या हुआ था. So one message I got from Smita, that is small for gestational age. Like our discharge slip should be having very clear mention, and we as a gynecologist, we treat across the generation and giving their antenatal care. We have a very good opportunity to follow that how small for gestational age succumb to metabolic disorder, we know, but all these pubertal issue also. This is very important. So that is the time right from the childhood we have to teach parents. It is a collective responsibilities actually. कि आपने बचपन से ही बच्चे को केवल फेरेक्स खिलाना या आपने बाहर का खाना या लंच आपने बाहर का दे दिया, बेबी विल नॉट डेवलप टेस्ट बड. और आप 16, 17, 18 या 20, 25 साल पे आप कहें कि आप खाना ऐसा खाइए, दे विल नॉट फॉलो, समहाउ दे डोंट फॉलो. लेकिन जो बच्चा शुरू से like they have the dinner lunch with their family and the fruits vegetable, they get taste for it. So pre-pubertal obesity is something which as a collective like issue we have to consider. And what Dr. Kiran says, that the environmental issue, mineral water bottle, packaged food. So these are something हम पूरे planet को नहीं बदल सकते. वो पूरी डेवलपिंग वर्ल्ड, a lot of political and financial issue. लेकिन हम अपने घर में जरूर सबको बदल सकते हैं. We can totally omit all packaged food. We can totally omit all cold drinks, which is the extra source of estrogen as well. And people must know, क्योंकि इट इज ए हाई फैशन ना, एवरी सेलिब्रिटी सेइंग, आमिर खान से लेके शाहरुख खान सब उसी को प्रमोट कर रहे हैं. सो our work becomes very, very difficult. But what you say, to see the 4th, 3rd year girl with the menstruation, and it is such a painful thing that our combined effort can really go a long way to have all these PCOS problem, obesity problem, then reproductive problem, as of course the precocious and the pubertal disorder. So these are the few things we have learned together कि सारे जो विचार से जो आगे की दिशा मिलती है. And that was great, Sarika. To my Archana, Ritu, and Sarika, if you have any question or any experience, please you share before we close. Dr. Madhu is with us.
I just wanted to know one thing was, in a case of infantile pubarchy, when to rule out congenital adrenal hyperplasia?
Congenital hyperplasia in a newborn, if it is salt wasting, you don't need to do. By 2 weeks, the baby will only present with features. But isolated pubarchy, your first line of management or investigation, whether infantile or non-infantile, should be ruling out CAH, because CAH is the commonest cause of peripheral precocious puberty in children. So you have to rule out CAH irrespective.
So which test should we do? DHEA?
17 OHP, 17 hydroxyprogesterone. Age-related cutoff values are there. 17, one single test is enough.
Okay.
17 OHP.
Ma'am, my last question is when not to treat, and just reassure the patient, okay, you are fine, we just want to follow you up and we don't want to treat you.
So any child who presents, any girl beyond 9 years, I don't treat. Unless very, very short or is a special case. Less than 8, I always treat. 8 to 9, fast progressing puberty, I treat. To treat, otherwise don't treat. So less than 8, treat. More than 9, don't treat. But broadly, 8 to 9, case to case. Fast progressing, short stature, you can choose to treat.
One thing I have to ask, like once you have decided you are treating, so what is your checklist during their follow-up when you are calling them for the follow-up to your OPD?
I had shared a slide. So by 6 months, so the first 3 doses, or at least the first 6 months, you will not see any massive changes, barring the girls who've come with menarche. After the 3rd dose, menarche will stop. First and second dose ke baad, they can have intermittent. By 6 months, the bone age progression will slow. By 6 months, the puberty, pubertal or pubarchy, matlab hair in the pubic area and axillary hair will stop or slow. Breast budding, which has happened, will become soft. The pain will go away.
For the bone age, you are repeating those X-rays of that wrist?
Left hand and wrist.
Okay, yeah, thank you.
Now I think we should.
Yes, thank you. Great discussion. बहुत मजा आया. Very nice.
Very
Archana,
informative
Ritu,
lesson.
Sarika, very. I think you made the like a very you made roads into the forest. We had a quite clarity on certain things.
Very, very informative. Yes.
So,
now, should I put my
everybody will have benefit.
Yes.
Your
Thank you
vote.
so much, ma'am, for having us here.
Always a pleasure. Always pleasure. And Smita, you are our like you become member of NIGF as well.
I will, ma'am.
Sadha
ma'am, anything for you. Ma'am has the kind of opportunity she gives. Like she kind of promotes you. She encourages you to
That is very true,
speak
Dr.
on this platform. This is a huge opportunity. I can't thank her enough. All of you for being so encouraging, so interactive. It's been wonderful. It's been a complete honor for me.
We are also very lucky to have her in Gorakhpur, really. Acha, now I'm going to thank, on behalf of the team members and the organizers, I extend my heartfelt thanks to everyone. I'm grateful to all who have taken out time from their busy schedules. I thank Dr. Manju and Dr. Sushma Chawla ma'am for their blessings and Dr. Sharda madam for her valuable guidance all throughout. I thank all the experts and particularly our speaker, Dr. Smita Ramchandran, for a very informative and knowledgeable deliverance. You've really given us a lot of encouragement so that we go in deep into the precocious puberty. And I'm forever thankful to Dr. Sadhana ma'am for her tireless pursuit for organizing such platforms to impart knowledge. And I'm thankful to the panelists for their active participation and for a very nice session and very entertaining session. And last but not the least, I would thank the Corona team, especially Mr. Pranjal, who has taken pains to organize this event. Thank you very much. Thank you so much.
Ritu and I thank you very much. I leave all responsibility to you. When you are at helm of affair, I have no worries. So, Pranjal, please share what was the attendance and share the recording. So we will
Sure,
put
ma'am.
on
I
the
already
chat.
sent the recording in the WhatsApp group, ma'am. YouTube
Okay,
link.
okay, great.
Yeah.
So we put
Personally,
on
I'll share you the total attendance.
yes, yes. So we can say good evening, good night.
Right.
So
Yes.
Thank you so much.
thank
Okay, ma'am. Good
thank-
night.
Thank you.
Thank you
Thank
very
Should I end the session, ma'am?
I think
yes, yes, you can end the session. You can end the session.
Okay, ma'am. Bye-bye. Take care. Bye.
Bye.